All right, so we talked about reflexive and voluntary movements, and now we're going to talk about involuntary movements. So I have to get up to page 31, I think. Okay, so there are lots of different types of involuntary muscle contractions, including muscle cramps. We've all had those. Fasciculations, myoclonus, abnormal movements that are generated by dysfunctional basal ganglia, and we will talk more about those in the basal ganglia chapter, like tremors, fibrillations, and tremors. Back up to there. So all of these involuntary contractions, the first four can occasionally occur in a healthy neuromuscular system. They're not necessarily signs of pathology, but they can be signs of pathology. Usually, fibrillations and tremors do not appear in a normal system, but all those other things can. Muscle cramps are severe, painful muscle contractions lasting seconds to minutes. We've all experienced those for different reasons. Muscle cramps are considered to be high-frequency discharges of motor neurons overstimulated by sensory and motor tract input, and that causes muscle cramps. So people always ask about muscle cramps in therapy. Patients always ask. And everybody has their old, well, I hate to say old wives' tale, but their home remedies will say for muscle cramps. People say, oh, eat a banana every day, or whatever. There are a million of them. But there are tons of different things that can cause muscle cramps, and usually the two things that can, or maybe three things that can resolve muscle cramps are stretching, activation of the antagonist muscle, and sometimes massage, rubbing the muscle, some mechanical force on there. So there are lots of different things that cause cramps, and eating a banana every day is only going to cure them if nutritional deficiencies are part of the reason you're having cramps, but there are a million other reasons you could have them. So really the answer is how to stop having cramps is figure out what's causing them. But when you have one, stretching it, activating the opposing muscle group, or massaging it are the three things you should probably do. So fasciculations are quick twitches of all the muscle fibers in a single motor unit. They're visible on the surface of the skin, that like twitchy muscle thing. An example of a fasciculation is like an eyelid twitch that sometimes accompanies anxiety, or if you've been reading your neuro book too much and your eyes are tired, you can get those eyelid fasciculations. They don't really know why. They don't know what the physiological cause is. So kind of interesting. Even though we've all experienced it, we don't know why it happens. So myoclonus, also known as clonus, is a brief involuntary contraction of a muscle group or a group of muscles. Myoclonus is the explanation for hiccups and muscle jerks, restless leg, that sort of thing, when people sometimes experience when they're falling asleep. When you're awake in a normal neuromuscular system, they don't know what causes that. Sleep onset myoclonus occurs when the wake-sleep transition elicits spinal motor neuron activity. So, take that for what it is. It's that you're falling asleep and your spinal motor neurons are activating your muscles. So then getting into sort of the pathological area, fibrillations are random, spontaneous, brief contractions of single muscle fibers that are not visible on the surface of the skin. So those fasciculations, they're visible, you see twitching. Fibrillations are always pathologic. So fasciculations can just be something happening in the normal nervous system, but fibrillations are always pathologic. It occurs when a muscle membrane is unstable owing to denervation, trauma, or electrolyte imbalance. So fibrillations are always a pathological occurrence. Tremors also pathological. They are involuntary rhythmic movements of a body part. Physiological tremors can be enhanced by, not necessarily caused by, but enhanced by anxiety, stress, fatigue, medications, metabolic disorders, caffeine, or alcohol withdrawal. So resting tremors are most visible when a person is not intentionally moving. Postural tremors occur when a body part is maintained against gravity. There are also action tremors, which are when you are actively moving, intentionally. In Parkinson's disease, the tremor is typically a resting tremor, mainly in the hands and lower limbs. So you'll see people that have what they call a pill rolling tremor, where they're like their fingers and thumb are sort of going together like they're rolling a little pill. Usually in early stages of Parkinson's disease, the tremor affects one upper extremity, and as the disease progresses, it could affect bilateral upper extremities. But the tremor is typically the symptom that makes people seek medical attention in Parkinson's. Cerebellar tremors are usually intention tremors, which happen when you're trying to do a voluntary movement. Psychogenic tremors are characterized by sudden onset and remission. So the most common pathological action tremor is called essential tremor. Essential tremor is both postural and intention tremors, predominantly affecting the head and hands. So it interferes with eating, holding a spoon or a fork, drinking, brushing your teeth, combing your hair. The voice and lower limbs and trunk may also be affected with essential tremor. So it's usually a lot of essential tremor cases are caused by an autosomal dominant gene trait. In Parkinson's disease and related disorders that have to do with the basal ganglia, it's typically a resting tremor rather than an intention tremor. And some of the Parkinson's related disorders can also have action tremors. So cerebellar tremors are usually intention tremors that are absent at rest, and a lot of times they're more severe during the final part of a movement, like to press a button or complete a movement. So cerebellar disorders can also cause postural tremor. So psychogenic tremor can be any of the tremor types because there's something else causing it. And a lot of times with a psychogenic tremor, it significantly diminishes or disappears when the person is distracted. So pretty interesting. But so when we're talking about motor neuron lesions, lower motor neuron lesions, if the motor neuron cell bodies or axons are destroyed, the affected muscles are denervated, and you get loss or decrease of reflexes, paresis or paralysis, muscle atrophy because it's not being innervated, decreased muscle tone or loss of muscle tone, and fibrillations. So those are those random brief contractions that can't be seen on the surface of the skin. Because the motor neuron is the only route from the spinal cord to the muscle, motor neuron lesions interrupt the efferent limb of the reflex. So you get the input from the afferent, but then you don't get the output because there's a lesion on the motor neuron. Complete loss of the ability to generate muscle force is paralysis. Decreased ability to generate muscle force is paresis. And it's a common consequence in motor neuron, lower motor neuron lesions. So the complete lesion of a peripheral nerve produces paralysis because the motor neurons are the only pathway from the central nervous system to the skeletal muscle. Muscle atrophy is loss of muscle bulk. Disuse atrophy just results from sitting on the couch too much, lack of muscle use. Neurogenic atrophy is caused by damage to the nervous system. So motor neuron lesions cause two different types of abnormal muscle tone. Hypotonia, which is decreased muscle tone, or flaccidity, which is absolutely no muscle tone whatsoever. So that's all we're going to say about that. So there are two types of electrodiagnostic studies that are performed on motor neurons: nerve conduction studies and electromyographs. So we talked about nerve conduction studies in the one of the somatosensory chapters. Electromyograms, the activity of a muscle is recorded from the skin overlying the muscle. So you have electrodes recording that information. So the purpose of nerve conduction studies in motor disorders is to differentiate among three possible sites of dysfunction: either the nerve, the neuromuscular junction, or the muscle. So they stimulate the skin over a nerve, and they record the potential from the innervated muscle, the electrical potential. Surface EMG, the electrical activity of a muscle, is recorded from the skin. Diagnostic EMG requires inserting a needle electrode directly into the muscle. And I've had it done, and it hurts. I mean, it's not horrible, but it's not the most fun thing in the whole wide world either. So myopathy that's detected by electromyography is an abnormality or disease that's intrinsic to muscle tissue. So the EMG is the attempt to say, is it a nervous problem, is it a neuromuscular junction problem, or is it a muscle problem? Muscle electrical activity is recorded when they first insert the needle into the muscle, during rest, during a minimal voluntary contraction, and during a maximal voluntary contraction. During rest, you can get fibrillation, which is always abnormal, or fasciculation, which could be normal or abnormal, depending. Signs of denervated and reinnervated muscles versus myopathy. Fibrillations and a reduced firing rate during maximal voluntary muscle contraction indicate denervated muscle. In primary disease of muscle, axons innervate fewer than normal muscle fibers, so you'll see this in post-polio syndrome. Myopathy is indicated by short duration, low amplitude potentials during voluntary contraction. Do you have to remember all this stuff? No. But if you just remember that, like, oh, what was that electromyography again? I will look in my neuro book. You will know that. So in the next section, we will talk briefly about disorders of motor neurons.